Hi, I'm Deborah Sims from Lymphoma Australia, here on behalf of the Lymphoma Coalition, and I'm here with Stephan. Stephan, tell me about where you're from in Germany and your university.
Right, so my name is Stephan Stilgenbauer from Ulm University and Saarland University at the moment, two positions. Very happy to talk to you today.
Thank you. There is so much here at the conference at ASH 2019 on CLL. There's so many exciting molecules. The parameters for treatment are changing substantially. What is interesting you as much at the conference?
Right, so I think, in the past we had chemotherapy only. Then we had ibrutinib coming down the road, and now venetoclax. And the next generation BTK inhibitors, such as acalabrutinib, have really made it to phase 3 and became licensed in the US and will be licensed across the world, we hope. So we have a whole new spectrum of single agent treatments, and then we have the combinations of these novel agents all together. We've seen first data that looks very, very promising with a hope for time-limited therapy.
Now, you're involved with a trial with obinutuzumab and venetoclax and presenting results here. Tell us about that.
So in that trial, CLL-14 trial of the German CLL study group, obinutuzumab venetoclax as an experimental arm was compared to obinutuzumab plus chlorambucil, one of the standards for elderly unfit patients, so unlike you. So in this trial, obinutuzumab venetoclax improved dramatically the progression-free survival for the patients with unmutated V genes, but now in the most recent analysis also for patients with mutated V genes, so for the good prognostic group. So here we clearly show that with these novel agents, not only the poor risk patients, but across the board, all patients can benefit from these new treatment options.
And what does this mean for the future of things like FCR and chemoimmunotherapy treatments?
So I think chemotherapy, FCR, BR, chlorambucil-based therapies will be used less and less. From my perspective, clearly the frontline treatment should be ibrutinib or venetoclax. Second line, then probably the other one of those that you didn't choose in the frontline setting. Potentially in the future, novel combinations, possibly also including an antibody with a hope for time-limited therapy. And then comes chemotherapy. With time-limited therapy, obviously you do not have this treatment as one treatment option, but when you had a long time off treatment, you can reuse that treatment. So you gain not only another agent, you gain a whole set of new series of treatments potentially.
And there are substantial benefits to time-limited therapy for your patients.
I think so. Time off therapy is still the best time. It's not only reducing cost, but also side effects are reduced. And to me, the key option is really if you had a response and treatment-free interval of 2, 3, 4, 5 or more years, you can just retreat with the same regimen.
Wonderful. Thank you very much. Enjoy ASH and look forward to hearing you present.
Thank you, Deb. Thank you very much.